welcome to the deep dive.
Great to be back.
So we're built on this one simple premise, really. We think you deserve to be the most informed person in the room, and you deserve it fast.
Which is why this week you sent us diving into a really fascinating stack of nursing research papers, all recent, all from PubMed.
Hot off the presses. We're talking December 2025 findings. And what we found was, well, it was a really clear story about the two big forces shaping modern healthcare.
It really is. It's this constant tension. On one side, you have what we're calling the blueprint.
Right. The hard science, the evidence-based protocols, the standardized pathways, all designed to eliminate mistakes and make care perfect.
And on the other side, you have the human reality.
Which is messy. It's where culture, fear, ethics, and just, personal values come crashing into that perfect blueprint.
And they refuse to fit into a neat little box or a checklist.
Exactly. So today, we're exploring 5 really diverse studies from the NICU all the way to psychiatric care to figure out when that scientific blueprint works perfectly and when care suddenly turns into a really complex negotiation.
Let's get into it.
So let's start squarely in that first territory, the blueprint.
Yeah, let's talk about where it works incredibly well. We're looking at how standardizing care, even really basic stuff, can just have these huge impacts on outcomes.
And our first paper, source 5, is about neonatal hyperbilirubinemia.
Or jaundice in newborns, basically.
And what I found so amazing about this study, which looked at something called bundle nursing, is that the big innovation wasn't a new drug or some fancy machine.
No, not at all. It was just about taking proven, simple care steps and packaging them together into one mandatory, comprehensive bundle.
So things that people were probably already doing, but maybe not consistently?
Exactly that. They took common sense things that might get forgotten on a busy shift and made them a concrete protocol.
Like what, for example?
Well, things like gently repositioning the baby every 2 hours during phototherapy, just to make sure the light hits all of the skin. And crucially, focusing on nutrition to, promote excretion.
To get the bilirubin out of the system.
Right. Specifically ensuring the passage of meconium. No single part of that is new, but making it a mandatory system was.
And the results.
They were just crystal clear. The bundle nursing group saw their jaundice clear up so much faster than the standard care group.
Wow.
And not just that, they measured better developmental outcomes, more weight gain, more length gain, and they had 0 cases of severe hyperbilirubinemia.
So the takeaway here isn't just that, turning a baby over is good.
No, the real value of the bundle is that it creates a shared blueprint, a simple goal that improves communication and consistency for the entire team nurses, doctors, even the family. It just sets a new floor for quality.
And that idea of a blueprint fixing systemic issues, not just clinical ones, it applies to more than physical checklists.
Oh, absolutely. Which brings us to source 1. This one looks at evidence-based nursing, or EBN, for patients recovering from a stroke.
Acute cerebral infarction.
Right. And this is a perfect example of the blueprint moving beyond just the physical body. This EBN protocol didn't just focus on, say, helping a patient walk again. It intentionally standardized the psychological recovery.
Which is so often overlooked.
Completely. The rates of anxiety and depression after a stroke are incredibly high, so they basically standardized the soft skills.
What do you mean by that?
Things that used to depend on an individual nurse's experience or, just their personality, they turned things like planned psychological chats and specific counseling techniques into part of the daily routine.
So they made empathy part of the protocol. What were the gains?
They were huge. The EBN group had significantly lower scores on the depression and anxiety scales. I mean, a measurable drop in their mental health burden.
And did that affect their physical recovery?
It seems so. They also had better cognitive function scores and were more independent in their daily activities.
So the big insight here is that EBN isn't just a to-do list for the body. This blueprint forces the integration of mental and physical health.
It raises the baseline for everyone. It makes sure a patient's anxiety isn't just ignored because the nurse is, busy focusing on their mobility.
So this is the blueprint at its absolute best. Clear, objective, unambiguous.
Lower the bilirubin.
Yeah.
Reduce the anxiety. It works.
But the moment you introduce variables like culture or fear or even just convenience,
that's when the blueprint starts to fall apart.
And that pivot takes us right into the messy stuff, the human reality.
Yeah, let's start with a study that it shines a light on a massive systemic issue, source 2. It looks at the preference for C-sections in Andhra Pradesh, India.
The numbers here are just staggering.
They really are. The WHO recommends a C-section rate of around 10 to 15%. Medically, that's what you'd expect. In this region of India,
It's 42.4%.
42.4. So when you see a procedure being used 4 times more often than it should be, you know something else is going on.
It's not just about medical need.
Not at all. And the analysis found 3 big drivers. First, sociocultural factors. There's deep maternal fear-tocophobia, it's called, a real pathological fear of childbirth.
And family pressure, I imagine.
Huge pressure, and even the cultural desire to have a baby born on an auspicious date.
No clinical guideline can argue with that.
Exactly. Then you have lifestyle factors like sedentary behavior and just plain old convenience. But the third driver, for me, is the most troubling.
The healthcare system itself.
Yes. C-sections are predictable. You can schedule them. Natural labor is chaotic and unpredictable. For a hospital dealing with staffing, a scheduled surgery is just easier.
And there was a medico-legal angle, too, wasn't there? Yeah. Doctors choosing surgery to avoid the risk of a lawsuit if something goes wrong with a natural birth.
Precisely. So the decision to do a C-section stops being a clinical blueprint. It becomes this complicated negotiation between fear, culture, and what's convenient for the hospital.
The conclusion is pretty damning, then. Without major education and regulatory audits, the medical guidelines are basically just suggestions.
They're irrelevant in the face of these other pressures. And think about the nurse or midwife in that situation. They're not just following a protocol anymore.
They're a culture broker, a negotiator.
And that ethical weight on frontline staff is immense, which actually is the perfect lead-in to our third source.
Okay, this one really stuck with me.
Source 3, it's about midwives who were part of a placebo-controlled trial for labor pain relief.
So clinical trials, the absolute bedrock of medical progress. We need them.
We do. But for the midwife in the room, the reality is a patient in agonizing pain.
And the conflict they felt was intense.
It was. On one hand, they totally supported the research. They want better pain relief for their future patients. But on the other hand, they felt this crushing guilt that they might be giving a sugar pill, a placebo, to someone in terrible pain right now.
And that's where that scientific term equipoise becomes a real human problem.
Explain that.
Well, equipoise is this idea that to run a fair trial, the staff have to be genuinely uncertain which treatment is better, the new drug or the placebo.
But how can you be genuinely uncertain when your entire professional instinct, your entire being is screaming to just help the person in front of you, to make the pain stop?
You can't. It's an impossible situation. The blueprint of the trial says you must follow the rules. But their oath as a caregiver says they must provide relief.
And it creates this moral injury. And then there was the practical side of it. They talked about how incredibly hard it was to even get informed consent.
I can't even imagine trying to explain a double-blind trial to someone in the middle of active high-intensity labor.
Right. In that chaos, it just shows that all of our medical progress, it rests on the emotional and ethical capital of these frontline staff. They're forced to be both healers and data collectors at the exact same time.
So we've seen the blueprint work for physical care, and we've seen negotiation take over because of culture and ethics.
But now let's look at a place where the blueprint itself is just broken, where a historical bias has created this massive blind spot in care.
This is source 4, and honestly, the findings here felt like a punch to the gut. It's on psychiatric nurses' views of sexuality in patients with mental disorders.
It's a tough one to read. The study found, pretty bluntly, that psychiatric nurses often just disregard the sexuality of their patients.
They disregard it.
They ignore it. And they reported that they don't have the skills for sexual care or counseling. And this wasn't just 1 or 2 nurses. It was a clear pattern.
Now, when you first hear that, you might think, okay, it's a training issue. We just need to add a class to the curriculum.
Right. But the study suggests the problem is so much deeper than that. It's an ugly societal prejudice.
What do you mean?
The analysis points to this unconscious assumption in society, this myth, really, that people with mental disorders aren't interested in sex, or that they don't have the capacity for relationships or marriage or having kids.
So it's about the denial of their basic civil rights.
That's what the study calls it. The themes they identified were all about this. Denial of civil rights, taboos, and a fundamental unwillingness from staff to even bring up the topic.
So because someone has a diagnosis, a core part of their humanity, their sexuality, is just erased by the very people who are supposed to be helping them heal.
It is an erasure of their personhood. That's the heart of it. This isn't just about a lack of clinical skills. It's a human rights failure. It's a dignity failure. And it's driven by prejudice.
So the challenge isn't just training.
No. The challenge is dismantling these deep biases that deny fundamental human experiences to a group that's already marginalized.
It really makes you question what blueprint we're even using. Is it a scientific one, or are we letting these archaic prejudices decide whose human needs are worthy of care?
And when the blueprint fails here, it's because dignity has been completely overwritten by bias.
So when we look back at all 5 of these studies,
Hmm.
you really see this map of modern care.
Yeah. You do. It's drawn right along the tension between these two forces. We absolutely need the clear, objective blueprint, the evidence-based nursing, the care gundles.
For efficiency, for better outcomes. The science is, in a way, the easy part.
It is. But we have to accept that in these other areas, where fear and culture and convenience and bias crash into a clinical decision.
Like with C-sections, or getting consent in a crisis, or affording dignity in mental health.
Then care becomes a negotiation, a deep confrontation with our messy human reality. The job of the healthcare team is to know instantly which of those two phases they're in.
And for you, as the informed patient or family member, it's just as important to understand that distinction.
Absolutely.
Which brings us to our final thought for you to take away. The next time you or someone you love is facing a big medical choice, I want you to stop and ask this question. Ask yourself and ask your provider.
The question is, are we in the blueprint phase right now, where the path is clear, it's standardized, and it's based on hard evidence?
Or are we in the negotiation phase, where my values, my culture, my fears have to be actively weighed and respected right alongside the scientific data?
Just knowing whether you're looking for certainty or looking for compromise can completely change the conversation.
It ensures your care honors both the best of medical science and the beautiful, messy complexity of being human,
A blueprint for the body.
and a negotiation for the soul. That was the deep dive. We'll see you next time.